This is Selma Schimmel, and you are looking live at the great city of Chicago, which is once again playing host to the American Society of Clinical Oncology, ASCO. This is ASCO's 49th annual meeting, and this year's theme could not be more appropriate: Building Bridges to Conquer Cancer. More than 30,000 of the world's foremost cancer specialists are here, and so is the Group Room, making our 15th appearance at ASCO and one of our very best. Joining me now is Dr. Heinz-Josef Lenz, Associate Director for Clinical Research and co-leader of the Gastrointestinal Cancers Program at the USC Norris Comprehensive Cancer Center. Dr. Lenz is Professor of Medicine and Preventive Medicine, Section Head of GI Oncology in the Division of Medical Oncology, and co-director of the Colorectal Center at the Keck School of Medicine at the University of Southern California. Welcome back, Dr. Lenz.
I'm happy to be back.
What's happening, on the forefront in the treatment of pancreas cancer, and what do we know about the increased risk of pancreatic cancer in BRCA-positive patients?
Yeah. So let's start with the good news. I think in pancreas cancer, for the first time, we have some move. Okay, about 2 years ago, we had the first data on FOLFIRINOX, the same regimen we just talked about in colon cancer, showing a dramatic increase in response rate, a dramatic increase in progression-free survival, and for the first time, survival over 1 year, unheard of. So we were very happy to have something in our hands. Now, this combination chemotherapy goes along with some toxicity, and that was the major criticism: can every patient be treated with an aggressive regimen like this? Now, then gemcitabine was combined with a novel drug. It's an albumin-bound taxane, okay, called nab-paclitaxel. And that is a very unique way, because pancreas cancer is different than any other of the solid tumors. When you look under the microscope, what you see that around the tumor cells, there is a lot of stromal tissue. And then the blood vessels come. So it's a not very vascular disease, not like liver cancer or colon cancer. So you can imagine when you have a lot of stromal tissue around the cancer, it is almost like a wall around it. Not easy to deliver the drugs. And this stromal tissue is not dead tissue, it's not scars. It's an extremely active microenvironment. A lot of pathway and communication go on between the fibroblasts and the tumor cells. In fact, the tumor cells communicate very well to get everything they need in order to survive and grow. Now, one of these elements in this space is called SPARC. It's a protein which is produced by tumor cells and by stromal tissue. Now, what makes SPARC so interesting? Because it binds to albumin. Now, when you have a drug bind to albumin, it will bind to SPARC, and it can be delivered much more successfully to the cancer. And that's the drug Abraxane, which works for breast cancer. So they used it in pancreas cancer, and the data were presented at ASCO GI for the first time. Further updates were presented here, and we see significant improvement in response rate, progression-free survival, and overall survival. So we have suddenly, from almost nothing, 2 effective agents. Now, who should we treat with one versus the other? We don't know. But I was actually hoping to see the SPARC expression data, because some data suggests that when you stain the tumor, it can predict the success of the gemcitabine and Abraxane, but we have not seen them yet. So that would be a very nice tool to decide one versus the other.
Are there any other studies that strike you at this meeting that you'd want to share?
So I think what's happening is that more and more taking advantage of the genomics. So I'm discussing in about an hour a completely new model for pharmacogenomic modeling for pancreas cancer, done at Sloan Kettering. So they have done in preclinical models, the avatar mouse, taking the tumor from the patient, the mouse, treating it, doing genetic analysis, and have a very complex mathematical algorithm saying, if you have this, you will be more sensitive or more resistant. And they tested it in patients for the first time. 32 patients, and their model predicted outcome. Not 100 versus 0, but very interesting, very impressive. I think This is the new wave, and the new way that we just don't use drugs like we do, but we understand and select and are really doing personalized oncology. This is the future.
Thank you, Dr. Lenz, Associate Director for Clinical Research and co-leader of the Gastrointestinal Cancers Program at the USC Norris Comprehensive Cancer Center, Professor of Medicine and Preventive Medicine, Section Head of GI Oncology in the Division of Medical Oncology, and co-director of the Colorectal Center of the Keck School of Medicine at the University of Southern California.
Thank you very much for having me.
Thank you for being back.